To start off, we have to look at the cycle of change as presented in our text with Murdaugh. We would start with the cycle as the pre-contemplation, no intention of changing behaviors. The contemplation, we are aware there's a problem. The preparation is the intent to take action. The action is the actual modification and changed behaviors. Maintenance is the new behaviors replace the old, and then it has sustained change. Therefore, numerous relapses and rehospitalizations would be prevented through utilizing this cycle of change. Interventions that are available in the community for COPD would include those of pulmonary rehabilitation, smoking cessation, as well as telemedicine. The targeted population would include that of the rural areas where defining exacerbation. According to Temple, it's defined as an event in the natural course of the disease characterized by a change in the patient's baseline dyspnea, cough, and or sputum and beyond the normal day-to-day variations. That's an acute in onset and may warrant a change in regular medication in a patient with underlying COPD. So what can be done to reduce these exacerbations? Well, my focus has actually changed from medication to more of the pulmonary rehabilitation, as I have done a lot more research in different areas, and they're really focusing on that. So the initial part of treatment with any of the patients that would treat, that is the assessment. It would consist of initial diagnosis that would be based upon lung function, spirometry, and to give a grade of the COPD and baseline oxygen saturations. So when it comes to grading the COPD with the spirometry, it can be a grade 1, which is mild, grade 2 at moderate, grade 3 is severe, and grade 4 is very severe. It's based on the spirometry test with result of the FEV1, and that's the amount of air that you breathe out of the lungs in the first second of forced expiration, and that's the initials, the F and the E. And so that severity increases as that forced expiration decreases. So that's how they would get assigned that, depending upon their spirometry. And I know another student had used that with COPD with spirometry. I just wanted a brief overview with what the grades are. In the health assessment, you would include the following of smoking: number of years, if they plan to quit, if they have quit. Weight is very important. Diet and exercise plan is equally important, so that way they get good nutrition, and also that person's gonna have more attainable goals and have the better follow through. Depression needs to be addressed because most people that have COPD, I believe the number is 85%, have depression of some kind. And that's because they tend to be isolated, the lack of energy, the unable to participate in normal activities. Go over vaccines if they've been given, which routine ones and when they're due, medications, what is going to be in part of the action plan. Advanced directives is also very important with a person with COPD, and as they further along in their grading, then it needs to be discussed about what type of things they would want to have done as far as end-of-life care. That is also on the American Lung Association's control plan, that the health assessment that gets done, they do talk about what their wishes are and if they have any of that in place. And then you also need to make sure to address other health conditions that could be contributing factors, such as cardiovascular disease, high blood pressure, diabetes, and how that would affect the lungs. And this assessment should be done every 6 months, then annually if symptoms are well controlled. Pulmonary rehabilitation. What is its primary purpose? Is to reduce symptoms, increase physical activity, and improve daily life. However, it's a path to breathing better. And once a person is diagnosed, then they will know how type of a serious debilitating condition this is. And what this pamphlet is showing is that the journey begins with their physical, their emotional, those well-beings, and then as well as their nutrition. Two and three patients who participate in this type of rehab, they report positive outcomes. 90% of patients who undergo pulmonary rehabilitation spend fewer days in the hospital. That is another goal, that COPD patients tend to have numerous exacerbations in a very short amount of time because they are not managing their symptoms at home. And then when the program ends, the goal is to also have increased physical activity and improved quality of life with those reduced symptoms. Benefits of the pulmonary rehab include that of having those patient assessments completed, having them done every 6 months, having them done annually. Therefore, that patient is going to be well taken care of. Tailored therapies, whether it be with physical therapy, occupational therapy. So then that way, physical therapy is working with breathing techniques and how to get to and from the bathroom and get up and down the stairs, how to conserve energy when eating. Exercise training is another important one that therapies can help with, because that way, if they have just types of stretching exercises, then they're still keeping those muscles limber and they're not going to, prevent them from moving or turning. Education on further symptoms down the road that they may experience, to reduce controlled breathing difficulties, learn more about the disease, manage the disease, maintain healthy behaviors, and what their medications would include, what the drug action is, how to use the inhaler, if they're going to have to wear oxygen, what kind of diet and nutrition are they going to have. It's very, very specific to each individual. And then once these items all start working together, then you're going to have behavior changes. They're going to want to start, having a little more activities and a little more control over what they're doing and get out more and just be a part of things. So exercising, some benefits that are very important with the COPD patient is that they will have improved use of oxygen, become less short of breath, less tired, able to do more and have more endurance, sleep more soundly, wake up refreshed, use less energy, and be able to breathe better. They will be able to know when their symptoms are worse, what makes their symptoms worse, and then how to control them. And then they might even be able to find ways to relieve stress through yoga, through stretching. Exercising is very, very important to a COPD patient. So one thing that I can't stress enough is that the rural population, especially since COVID, has been really hit hard with being on their own, in their own homes. And telemedicine has become a very big part of some COPD activities, as well as outreach programs. And there's this particular quote that was in this article that I read, that telemedicine can't increase capacity, it can increase access to care. And how true that is, especially in Kansas, where I'm at, out in the western area, the northwestern and the southwestern parts of the state, where the next town may be an hour and a half away, and that next town may only be 100 people. So having telemedicine for COPD patients is starting to become very important. And since COVID, the rural areas have come to rely more on the telehealth services due to being homebound. But what about those that would benefit from services that don't have access? There are many barriers to consider the internet capabilities, the lack of healthcare due to the telemedicine. Can be difficult to get an accurate assessment because you're not always able to listen to the breathing. You can watch how they breathe, but not necessarily listen. You would have to have things in place in the home through an initial setup that they would have to have blood pressure monitors, oxygen saturation monitors, and the spirometry and monitors in place. So then that way the telemedicine would be more effective. And then there are no evidence-based guidelines for telemedicine in regards to COPD, as well as the sustainability of it. So I touched on it just a bit here. So it can be seen that you can do a physical assessment and have a diagnosis through telemedicine and treat them, have some exercise training, patient education, as well as the maintenance program. And then you can do self-management and intervention with the patient interview. So that way, all of those items that I've already touched on of what would be important in an assessment could be also addressed and then could be kept for documentation purposes. So the most important takeaways that I think I have really taken from doing pulmonary rehabilitation with COPD is once you're diagnosed, is keep follow-up appointments and make regular appointments. Know your numbers, including spirometry, labs, and your baseline. Follow your action plan. Action plans are going to tell what kind of medicines you're going to take that are going to be normal if you have no symptoms, what you're going to take in an emergency, and then when it's time to call 911 or make a trip to the emergency room. Then that plan is also reassessed every 6 months and yearly unless there's a hospitalization. And then that follow-up should be done within the first 7 days after hospital stay. Keep an inhaler readily available, whether it be your steroid, knowing which one you need to take if it's a sudden emergency or the one that you're going to do routinely. Treat other conditions such as the heart disease, the diabetes, the weight. They all are intertwined with one another. Eat a healthy diet as much as possible. Avoid smoking or other lung irritants. That is going to be one of the biggest things to be able to do, especially for a person with COPD, is they can't be around that extra smoke type of thing. So smoking cessation for a person who is diagnosed with COPD is extremely important. So a few things to do is to include it in the health history every single time. Years smoked, or how have they smoked in the past, exposure to secondhand smoke, exposure to lung irritants that are on the job, such as dust, asbestos, farm dust, chemicals, any type of irritant that's going to make the lungs not function like they're supposed to. And just like a pain agreement, produce a smoking agreement, and it will be addressed at every visit. And with that, you're going to put in there, they're going to have a goal in mind. These are the steps we're going to take to get to that goal. And you're going to revisit it every single visit until the goal is achieved. And then after that, then come up with a new goal. I think with a person that's going to have COPD, the best intervention to have is going to be to remain off of oxygen as long as possible and increase that lung function. So there are resources available out there for the community that I live in by Salina. We have the Salina Regional Health Center Pulmonary Rehab Department, which folks can go to the hospital and they can perform rehab exercises with the cardiovascular rehab as well. Utilize support groups such as exercise groups, smoking cessation groups, faith-based groups for stress relief and for reducing stress. Then across the national stage, there's the American Lung Association, the COPD Foundation, the National Institute of Health, the CDC. There are so many out there that I can't list all of them. Then there's so much information, and it's going to depend on each individual practitioner of what they're going to have in their practice and how they're going to address that for the future. My references, and thank you for listening.